How do we use steroids when we're using an immunomodulator? How do we use a steroid as part of the induction process to the treatment? The reality is that the worse we see, the worse the disease process, the greater the likelihood that we're going to have side effects from any immunomodulator on the market. If you see severe inflammation on the surface of the eye and you simply prescribe the immunomodulator that you know your patient needs long term, you run the risk that they're going to reject that therapy simply because there's going to be a doubling down on their symptoms because of the immunomodulators. The more rapidly you treat the inflammation, the more likely they are to be accepting of the immunomodulator treatment itself. The other thing that you have to remember is that your success as a physician in the eyes of your patient is dependent on how rapidly you make them feel well. If you put them on a steroid as part of the induction process, you're dramatically accelerating their improvement in symptoms. You're making them feel better faster.
So how do you use steroids to treat inflammation in ocular surface disease? So the critical decision is, where are they on the cycle? If they're early and they have mild inflammation, you can use a T-cell inhibitor like a liftograst or a cyclosporin. If they have chronic long-term disease or intense inflammation, we need to go to the steroid group to accomplish their therapy. We often use steroids as an adjunct therapy in patients that are already on immunomodulatory medicines like cyclosporin and liftograst. And I like to use Flarex for two main reasons. First of all, its efficacy profile is very similar to prednisolone acetate, so it's a very strong steroid, and many physicians don't recognize the strength of this compound. The other thing about the Flarex is that since it's the acetate version, it's better than FML in terms of penetration into the tissue, and it has a very similar safety profile to FML, which is much less likely to induce the complications of steroids, such as elevated intraocular pressure, cataract development, and susceptibility to infection.
I like steroids. I think steroids are really a mainstay of a treatment for a flare-up for dry eyes, and for many reasons. Number one being it works, and it works quickly, and it knocks down the inflammatory response quickly, and that's what patients want, and that's what they need. Provided that your patient's coming in, you've ruled out any infection, bacterial or viral infection, and you see the classic signs of a dry eye flare-up, I reach for steroids much more so than I did in the past. Before, it was, here, take some artificial tears, you know, get out of here, come back and see me in a month, or, you know, if you're not feeling better. Now it's often the patients have seen multiple doctors, they're frustrated, they want some instant relief. We live in a society where it's an instant gratitude. Everyone wants instant results. So this gives them nearly instant results. And it's an important way to break the cycle of the inflammatory cascade that builds up in dry eye disease. If you don't treat the flares, that's where the damage happens in chronic dry eye disease.
When I have a patient on a long-term immunomodulator, I really like to use a steroid as an induction therapy. What I like to do is I like to start a steroid right when I start the immunomodulator. And what that does is it helps me treat that inflammation quickly. It helps me get my patients feeling better more quickly, and it gives time for that immunomodulator to kick in. So what I do is I have a patient use 1 drop of steroid like Flarex, and then wait 5 minutes, and then have them start my immunomodulator of choice.